from 9 to 10 a.m. Each hospital would present its case according to the schedule. One hospital would be the lead. Now, I want to introduce you all with the history of our department, our team members, and what are our aims and objectives. This department was founded in the year 1974, and it is attached to Civil Hospital Karachi and Dow Medical College. The first head of department was Dr. Zafar Ahmed, and Professor Zarnaz Wahid became the head of department in the year 1992. We run a 30-bedded ward and an OPD. This department has the honor to be the first department recognized for FCPSP training in Sindh by CPSP in the year 1994. And this was made possible by the hard work, struggle, and sincere efforts of Dr. Zarnaz and her team, including Dr. Anjum Kanji, Dr. Abdul Aziz, and Dr. Seema Zia. Our leading team members are our hardworking faculty, Dr. Humaira Tallat, Dr. Reema Mirza, Dr. Maria Mansoor, and consultants, Dr. Asma Muzammil, Dr. Shadia Wahidi, and Dr. Fareed Ashfaq. Since the inception of FCPSP training in our department, more than 25 candidates have cleared their examination successfully, and currently we have 16 candidates under training. Also, more than 40 DDM candidates have cleared their examination successfully from our department. We conduct a structured training with daily ward rounds, daily OPDs, 2 days a week minor procedures, and 3 days a week academic sessions to promote the teachings of our DDM and FCPS trainees. Our aim is to provide our best of services to the patients and to train skilled and competent future dermatologists. These are few of our department's ward and OPD activities. We have 3 days a week academic session where every Wednesday there is a grand topic presentation with 2 clinical cases discussion. Every Thursday, short and long cases are performed, and every Saturday, clinical slide sessions and 2 J clubs are discussed. In the year 2021, we conducted FCPS2 mock tests at Civil Hospital Karachi, and FCPS2 exam candidates from all over Sindh were welcomed. These are all our department's team members after our department's Clinicopathological conference at Civil Hospital Karachi. World Allergy Day being celebrated at our department. Besides academic and clinical activities, we also have some extracurricular activities to lighten the hearts of our patients. On the occasion of Pakistan's Independence Day, a cake cutting ceremony was done by our department's senior most patient. Her name is Batul, and she is a diagnosed case of pemphigus vulgaris, and she is on our follow-up for more than 20 years now. In the end, it is not just about diagnosing the disease, but our main motto is to treat our patients well. And when we see them smile, it strikes us to work harder. Now, our first great case will be discussed with Dr. Zara Saeed, supervised by Dr. Humaira Tallat. Thank you.
Assalamu alaikum everyone. My name is Dr. Zara Saeed and I'm an FCPS trainee at Civil Hospital Karachi.
हाँ पर सारे अपनी ओपीडी में बैठे ताकि पेशेंट भी देखते रहे। हाँ बेचारे एक बंदा क्या एक बंदा आई।
I'll be presenting the first grey case of today's CPC. So this case is of a 52-year-old male who has no known comorbids, who is a resident of Thatta, and he has a government job. He presented to our OPD on the 29th of August 2021 with the complaints of multiple dark-colored polymorphic lesions on his trunks and upper limbs since 4 months, mild itching associated with these lesions since the last 4 months. According to the patient, he was in usual state of health 4 months back when he started developing small, red, raised lesions starting from his trunk. The lesions would enlarge in size and then become hyperpigmented and slightly scaled. Over a period of 4 months, these lesions increased in number and progressed to involve his trunk, bilateral upper and lower limbs. The lesions were persistent throughout the last 4 months. The lesions were associated with mild itching, but the patient denies any pain on discharge. On further inquiry, the patient is complaining of generalized weakness and having inability to perform his activities of daily living. There is no history of fever, weight loss, night sweats, or any chronic dermatosis. On his systemic review, he complains of exertion on shortness of breath on heavy exertion, but the other systemic review was unremarkable. His past medical and surgical history was insignificant. Drug history, transfusion history, and allergic history was insignificant. Family history, there is no history of any TB or any chronic illnesses in the family. There is no history of any addiction or smoking. The bowel habits are normal, but the patient is complaining of decreased appetite and sleep since the last 4 months. Moving on to the examination, a middle-aged male of average height and build, lying comfortably on bed, well-oriented to time, place, and person. On vitals on admission were blood pressure of 120 by 70 millimeters of mercury, pulse of 89 beats per minute. He was afebrile at the time of admission and with a respiratory rate of 16 breaths per minute. On general physical examination, he had subconjunctival pallor, leukonychia, mild pedal edema up to the ankles. Lymph nodes, a single lymph node was palpable in the right inguinal area, measuring around 2 into 1.5 centimeters. The lymph node was non-tender, mobile, and not fixed to the underlying structures. There was no jaundice, leukonychia, polynychia, clubbing, or cyanosis. JVB was not raised, and thyroid gland was not palpable. Moving on to the cutaneous examination, he had multiple light to dark brown hyperpigmented patches and plaques of irregular shapes and variable sizes over his body, predominantly affecting the trunk and the upper limbs, with a sparing of the face, scalp, palms, and soles. So these were the lesions the patient presented to us with. There were multiple patches and plaques. The plaques were mostly involving the trunk, and on the upper and the lower limbs, there were patches, hyperpigmented scaly patches. This is the largest lesion. It was present in the right flank area, measuring around 11 into 6 centimeters. It was extending from the right lower anterior abdominal wall, going laterally and posteriorly. The lesion was indurated, non-tender, mildly warm on palpation, and the overlying skin showed wrinkling and fine dry white scales. On nails, he had nail examination, he had colonychia. Longitudinal melanychia was appreciated on the right big toe. The scalp and the mucosa were unremarkable. On abdominal examination, he had a soft, non-tender abdomen. The liver was palpable, 3 centimeters below the right costal margin. The spleen tip was also palpable. There was no sign of any free fluid, and the gut sounds were audible. The rest of the systemic examination was unremarkable. So this is a case summary. We have a 52-year-old male who presented with a 4 months history of multiple hyperpigmented patches and plaques on his trunk and the upper limbs. On examination, there are hyperpigmented patches and plaques presenting over the body. The largest region present on the right flank area, which is mildly warm on palpation and not tender and indurated. Liver is palpable, 16 centimeter in span. Tip of his spleen and right inguinal lymph nodes are palpable. There is no history of any fever, like weight loss or chronic illness. So what would be the differential diagnosis? I would like to invite Dr. Humaira Talla to discuss the differential diagnosis for this case.
Thank you, Zara. So let's discuss the differential diagnosis. You have noted there are skin lesions and there is systemic involvement. What comes in your mind? What is the differential diagnosis of this case? Once you have examined the case, you have taken the history, then you should make a differential. So with this history and clinical examination, the differentials are, the first and the foremost important differential is lymphoma. So when lymphoma comes in your mind, what do you think? Either it is the lymphoma of the skin that has invaded the internal organs, or the lymphoma of the internal organs that has metastasized to the skin. Talk about lymphoma of the skin. They are divided in the same category as Hodgkin's and non-Hodgkin lymphoma. But cutaneous T-cell lymphoma are the most common, or the non-Hodgkin's lymphoma of the skin, and among those, mycosis fungoides is the most common one. Mycosis fungoides is one of the indolent cancer. However, in this patient, the history was very short, of only 4 months. So do you think with this 4-month history, is it possible that the internal organs are invaded? So what do you think? Is it a indolent cancer, or is it something aggressive one? If we talk about aggressive ones of the skin, then the two things that come in our mind are the Sézary syndrome or the tumor d'Amelin. But this is not the picture of either Sézary or tumor d'Amelin. And if we talk about Hodgkin's and non-Hodgkin lymphoma of internal organs, then the clinical features of the skin that these type of lymphomas can lead to are the pruritus, pigmentation, prurigo nodularis type lesions, ichthyosis, exfoliative dermatitis, or erythroderma. No such features were present in our patient. So there was a query whether the patient has, we are dealing with single entity, or are we dealing with two different diseases. But if you remember in the history and in the examination, though the history was short, but in the examination, one of the lesion was indurated and it was warm. When warm lesions come, usually we think of panniculitis. In this scenario, the type of panniculitis which you think is cutaneous T-cell lymphoma with panniculitis-like lesions. So what do you think? We are dealing with panniculitis-like T-cell lymphoma, or we are dealing with some other lymphoma that mimics mycosis fungoides and that has invaded internal organs also. And if you come across adult cutaneous T-cell lymphoma leukemia syndrome that is related to HTLV1, then the scenario fit in that. But the thing is that in that the blood picture, we will come to the investigation later on, but on the basis of history, you can think about that also. So the differential diagnosis we made at that time were lymphoma, as we have already discussed. Either it is the commonest mycosis fungoides, or it is panniculitis like T-cell lymphoma, or the secondary lymphomas that has metastasized to the skin, or we are dealing with cutaneous mets. Patient might have some underlying organ involvement that has metastasized to the skin. So we should think of cutaneous mets also. So with this, we proceeded with our investigations. Dr. Zara will discuss about the investigations. Then we will discuss it further. Dr. Zara.
Thank you, ma'am. So keeping these differentials in mind, the patient was admitted and a skin biopsy was planned after sending the routine investigations. The routine investigation showed an HB of 9.2 milligram per deciliter with an MCV of 84. The TLC count was also low at 2.3, with a neutrophil to lymphocyte ratio of 62 to 29% respectively. So on the basis of this bicytoclinic picture in the CBC, his peripheral film and relevant labs were sent. His LDH count came out to be markedly elevated at 3,879 international units. The retic count and uric acid came out to be normal. The peripheral film showed normochromic, normocytic anemia with anisocytosis and bicytopenia. His liver profile was unremarkable except for albumin, which is mildly low. His biomarkers were also unreactive. Biochemistry and coagulation profile were unremarkable. On imaging, his routine imaging was done. Chest X-ray PA view showed no significant finding, but the ultrasound abdomen showed hepatosplenomegaly with a liver span of 17.6 centimeters and a spleen of 14 centimeters. At this time, CT scan neck, chest, abdomen, and pelvis was also done, but the report was pending. As we got a CT scan done from outside civil hospital, as the machines were not in working order at that time, the radiologist demanded the biopsy report before handing out the report of the CT scans. So we had to wait for the histopathological report to get the CT scans. So what next? So up till now, we have a short history of patches and plaques. On examination, we have hepatosplenomegaly and inguinal lymph node palpable. And on workup, we got bicytopenia, raised LDH with a normal retic count, and hepatosplenomegaly also on the ultrasound. So the skin biopsy was received, which showed intact epidermis, unremarkable papillary dermis. The deeper dermis and subcutaneous tissue revealed nodules of atypical lymphoid cells with enlarged, rounded nuclei with prominent nucleoli and scanty cytoplasm surrounding the adnexal structures. There were foci of apoptosis and necrosis also seen. The immunohistochemistry came out to be positive for CD3, which was positive in the large cells, and CD4 was only focally positive in the large cells. The Ki67, which is a marker of rapidly proliferating cells, was positive in 90% of the tumor cells. They gave us the final diagnosis of a T-cell lymphoma, features favoring such as of mycosis fungoides. So now, moving on.
So, have you noticed that the skin biopsy favors mycosis fungoides, but you have to think of, and what I always request my PGs as well, that you have to read each and every line of skin biopsy. You have to go through the differentials as well, and you have to discuss about the biopsy with each other as well. So here you can see that clinically short history of patches and plaques with hepatosplenomegaly and lymphadenopathy. Do you still think that that this is mycosis fungoides? And have you noted then in skin biopsy, epidermis was quite normal, and papillary dermis was also not involved. So the deeper layers were involved. Still, do you think that it is mycosis fungoides? Because if we go back to the history and examination, we must have noted that few of the plaques were indurated and they were deep seated. If the plaques are indurated and deep seated, or the plaques are thickened, then epidermotropism is quite high in patients of mycosis fungoides. But in our case, the upper layers are quite normal. Still, we think of mycosis fungoides, we have to question ourselves if the upper layers are normal, still we are going on the right track, or are we missing something? And if we look into immunohistochemistry, you will see that CD3 positive in diffuse manner, that is quite well, or that is quite fine with mycosis fungoides, but CD4 is only focally positive. However, in such cases, CD4 is also diffuse positive, and Ki67 is positive. What is Ki67? It is basically a marker for rapidly proliferating lymphomas. It is not a marker for indolent lymphomas. So another question arises: are we dealing with indolent lymphoma, or are we dealing with some other lymphoma of aggressive behavior? At this stage, we were again thinking of panniculitis like T-cell lymphoma because the lesions were very deep-seated. But in panniculitis like T-cell lymphoma, epidermotropism is absent. CD4 is not seen or absent. However, the CD3 is positive and CD8 is positive. In our immunohistochemistry, CD8 is also negative. So are we dealing with panniculitis like T-cell lymphoma? Are we dealing with mycosis fungoides? We were, CT scan was awaited so that we can get some clue from CT as well. So Zara, let's discuss the CT scan of the patient. And we have already discussed this.
So meanwhile, we also received the CT scan report, which showed subcentimetric lymph nodes in cervical level 2 bilaterally, aortic area, and enlarged inguinal lymph nodes also seen. The largest one was measuring on the right inguinal region, measuring 2.0 into 1.5 centimeters. Skin thickening and stranding seen involving the anterior chest wall muscles along the sternum, measuring 4.8 into 2.0 centimeters, and there was no bony involvement. The spleen was measured 14 centimeters, and liver was enlarged at 17.5 centimeters. They gave us the final diagnosis of mycosis fungoides, and they reported The findings were consistent with the histopathological diagnosis. The reporting radiologist followed the diagnosis of the histopathologist instead of giving his own diagnosis or any differentials. However, CT scan is not the gold standard for diagnosing mycosis fungoides. So while we were still stuck in this dilemma, our patient developed sudden onset of right-sided weakness and slurred speech, and his urgent CT scan brain was done to rule out an intracerebral bleed. The CT scan brain was showed acute ischemic insult. He was shifted to the neurological HDO, where they ruled out the need for any intervention. CT angiogram was also done, which confirmed the ischemia. Patient was rehabilitated and shifted back to our ward after 5 days. So a question we asked ourselves at this time, that should we go for a repeat biopsy? This patient who had no comorbids, he was not diabetic, not hypertensive, normolipemic, with stable vitals throughout his admission, suddenly developed a cerebrovascular incident. This led us to think that maybe this cerebrovascular accident is actually a part of his widespread disease. So because of our strong suspicion of some other aggressive T-cell lymphoma, we decided to go for a re-review of the CT scan films. A second opinion of a CT scan of chest, abdomen, and pelvis was taken from a consultant radiologist. And he reported that the CT scan showed bilateral, multifocal, skin, subcutaneous tissue, and muscle infiltration on the anterior, lateral, and posterior chest and abdominal walls, encasing them. There was hepatosplenomegaly, bilateral subcentrimetric axillary and superior mediastinal lymph nodes, enlarged inguinal lymph nodes more on the right side, and the largest was measuring 2.10 into 1.8. And he reported that the overall findings were suggestive of a diffuse infiltrative process, most likely a lymphoma. So during the course of admission, a repeat biopsy was performed on the 21st of September 2021. And this time, a deeper chunk was taken from the infiltrative plaque on his right flank. A CT-guided inguinal lymph node biopsy was also done at the same time. The skin biopsy showed epidermis showed hyperkeratosis, follicular plugging, and variable acanthosis. There was lymphoid cell infiltrate in the deep dermis and the subcutis, which showed atypical medium-sized lymphoid cells with inconspicuous nucleoli and amphiphilic cytoplasm. These cells were also present in the lumen of the vessels, and there was apoptosis. Linear cores of fibrocollagenous stroma and areas of markedly crushed lymphoid cells were present in the lymph node biopsy. The dilated vessels showed similar atypical cells which were present in the skin specimen. On immunohistochemistry, it was pan-peak CD3 positive, CD5, CD4, and CD8 were reduced, and Ki67 was again reported to be extremely high, approximately 80 to 90%. So they gave us a final diagnosis of a high-grade T-cell lymphoma, the features favoring primary cutaneous peripheral T-cell lymphoma unspecified. So now I like to share a few words about this rare entity. Primary cutaneous peripheral T-cell lymphoma is a heterogeneous group of T-cell malignancies which are not defined by any of the recognized clinicopathological subsets. Mostly affect adult males, and the median age of presentation is 60 years. In all cases, mycosis fungoides must be carefully excluded, especially on the basis of the clinical features. Histologically, most cases shows numerous medium to large size cells with irregular pleomorphic hyperchromatic nuclei with frequent mycosis, and such cells were also present in the biopsy of our patient. They are characterized by an aberrant T cell phenotype that is usually CD4 positive and negative for CD8, CD5, and CD7, and the Ki67 rate is typically high for these tumors. The prognosis may be poor with a high probability of systemic involvement. So our patient also had systemic involvement from the onset and a high Ki67 rate. Initial treatment regimens include CHOP, that is cyclophosphamide, doxorubicin, vincristine, and prednisolone, and the EPOC regimen, that is etoposide, vincristine, doxorubicin, cyclophosphamide, and prednisolone. It requires prompt diagnosis and vigilant monitoring as it can be a life-threatening disease. A case report was taken from the Journal of Oncological Medicine 2015, and it showed a 78-year-old woman who presented to the ambulatory care with a 5 centimeter nodule on her shoulder that developed rapidly over 1 to 2 weeks. The biopsy results demonstrated CD4 positivity consistent with mycosis fungoides. Within 3 months, her cancer had progressed into diffuse lesions spanning her entire body. As rapid progression is not a classical feature of mycosis fungoides, the diagnosis was amended to PTCL-NOS, that is peripheral T-cell lymphoma, not otherwise specified. Cutaneous T-cell lymphoma should be suspected in patients with patches, plaques, erythroderma, or papules that persist. Singular biopsies are often non-diagnostic, requiring a high degree of suspicion if there is deviation from the anticipated clinical course. And multiple biopsies are often necessary to make the diagnosis. As similar thing what happened with our patient, that a single biopsy was not conclusive and we had to go for another biopsy to make the correct diagnosis. When we received this diagnosis, the hematology and oncology were taken on board and they advised to start the patient on the CHOP regimen and perform a baseline PET scan or a bone marrow biopsy. So a bone marrow biopsy was performed on 26th October 2021 and we wanted to stage the patient. The bone marrow biopsy also showed infiltration with abnormal lymphoid cells. So our patient landed in stage 3 with advanced disease. The patient was started on the CHOP regimen and he was planned for 3 to 4 cycles followed by PET scan to assess the response. So these are his lesions after 3 cycles of CHOP chemotherapy. As you can see that his lesions showed partial resolution.
Thank you, Zana. Here you can see a chart on your screen. This chart, we have taken this chart from Brooks textbook of dermatology. They have divided the primary cutaneous T-cell lymphoma into two: indolent clinical behavior and aggressive clinical behavior. And the one diagnosed by us is basically primary cutaneous peripheral T-cell lymphoma, otherwise unspecified or unspecified. So here you can see this primary cutaneous peripheral T-cell lymphoma, not otherwise specified, is a rare one. And it is one of the heterogeneous group where clinical features are not fit in one type of lymphoma. That's why they have created another group of this not otherwise specified. And our patient presented and with an aggressive behavior with 4 months history only. This is not possible with mycosis fungoides. So we should remember this thing that mycosis fungoides is one of the common presentation. But so many cutaneous lymphomas can mimic mycosis fungoides, and at that time, a proper clinical examination along with a good history is important. But in this case, I think you must have enjoyed the case. There was a series of events, and the beauty of this case lies in the fact that we have presented all the events in the same sequence as he presented to us. But the main issue is that if we would have gotten the correct histological and radiological report in the beginning, then he might have been treated earlier. So with this, I would like to end this case, and my take home message for my young fellows and my postgraduate trainees is that a good history and a good clinical examination is still of paramount importance. With this, I would like to end this case. The question answer session will be taken by the end of the second case. Thank you so much.
Now I would like to invite Dr. Batul Rahman to discuss the second play case of the CPC.
Assalamu alaikum. My name is Dr. Batul Rahman. I'm FCPS2 training in the Department of Dermatology, Civil Hospital, Karachi. Today, I'm going to present a case of 35 years old female married, resident of Sawat, farmer by occupation, who presented to us via OPD on 22nd of January 2020 with complaints of multiple nodular swellings on body for last 5 years and raised lesions on face for 3 years. According to my patient, she was in her usual state of health 5 years back when she noticed small pea-sized swellings on forearms initially, and with passage of time progressed to involve other areas of body, including legs and trunk. These swellings gradually increased in size, associated with mild itching, but not associated with any pain or discharge. This was followed 2 years later by raised annular pigmented lesions, developing on her left cheek, forehead, and chin over the span of 1 year with no associated pain, itching, or discharge. She denies history of photosensitivity, oral ulcers, or hair loss, and there is no history of cough, night sweats, or weight loss. On further inquiry, my patient complained of deformities of hands due to swellings, but denies any morning stiffness, pain, tenderness, or restriction of movement at these joints. Rest of the systemic review was unremarkable. Her past medical and surgical history was insignificant. She had a history of taking multiple courses of medications from local doctors, the names of which she did not remember. There was no allergy history, and her family history was also insignificant, with no history of TB or any other chronic illness in the family. Her personal history, including sleep, appetite, bowel habits, weight loss, and addiction, all were unremarkable. On physical examination, my patient was a middle-aged woman of average height and weight, sitting comfortably, well-oriented in time, place, and person. She was vitally stable. On general physical examination, she was mildly pale, with no jaundice, koilonychia, clubbing, cyanosis, edema, or dehydration. Her lymph nodes and thyroid glands were not palpable, and her GVP was not raised. On cutaneous examination, patient had polymorphic lesions. On face, multiple hyperpigmented indurated scaly plaques were present, one discoid rest annular with central atrophy predominantly involving nose, cheeks, and chin. Patient had gross deformity of both hands with fixed flexion deformity of right index finger. Bulbous swellings were present at proximal end of index, middle, and forefinger of the left hand. No tenderness, erythema, or limitation of movement were noted in these joints. On body, multiple skin-colored swellings of variable sizes were distributed over trunk and extremities. Swellings were soft, non-tender, mobile, with smooth surface, no temperature changes, and no discharge. Overlying skin was normal. We have not shared the picture of trunk because of privacy of the patient. It also had similar nodular lesions as can be seen here. In systemic examination, her abdominal examination, respiratory examination, cardiovascular examination, and central nervous system examination all were unremarkable. So to summarize my case, 35 years old female farmer presented with 5 years history of multiple skin-colored swellings of variable sizes on trunk and limbs, followed by multiple pigmented lesions on face and deformities of hands. On cutaneous examination, multiple hyperpigmented indurated scaly plaques were present with central atrophy on the face. Swellings on the trunk and limbs were non-tender, non-discharging, soft and mobile. Rest of the systemic examination was unremarkable. Now I would like to invite Dr. Maria Mansoor to discuss the differentials on this case.
So on the basis of this clinical history of 5-year duration and the clinical findings of indurated pigmented plaques and the soft tissue nodules, which differentials would you like to suggest? And here the question arises that are we dealing with two different clinical entities or are these a part of the same entity? So the differentials which we kept are: the first differential, which is an important one, is sarcoidosis, as sarcoidosis manifests with a variety of lesions ranging from papules, nodules, plaques, hypertrophic lesions, atrophic lesions, and so on. And it also has association with multi-systemic involvement, including the bone and joint. The second differential is infiltrative disorders like histiocytosis, either the progressive nodular histiocytosis, which is a non-Langerhans cell histiocytosis, very rare, and it presents with superficial papules and also the deep subcutaneous nodules, which are skin-colored and asymptomatic. Or the multicentric reticulohistiocytosis, in which there are nodules which lies in the close proximity of the affected joints. The third differential keeping in mind the profession of the patient. She is farmer by occupation, the long duration of the history, and the polymorphic lesion is subcutaneous or deep mycosis. The last but not the least differential is the cutaneous TB, because we are living in a TB endemic part of the world. The type of cutaneous tuberculosis which is most prevalent in Pakistan is lupus vulgaris, and out of its 5 types, the plaque variant and tumor-like variant fits with our case. The tumor-like variant presents with hypertrophic, either soft tissue nodules or hypertrophic masses. So let's see what the investigation reveals.
Coming on to investigations, her blood complete picture showed normocytic anemia with a hemoglobin of 10.2 milligrams per deciliter and MCV of 79.1 femtoliters. Her ESR was raised, that is 44 millimeters per hour. Her liver function tests, renal function tests including electrolytes and coagulation profile were all unremarkable. Her hepatitis B surface antigen, anti-hepatitis C virus antibodies, and HIV serology were all non-reactive, and her MON2 test was also negative. Her ACE levels were within normal limits, that is 15 nanomoles per milliliter per minute. In imaging investigations, her chest X-ray was normal with no lung pathology appreciated. Her X-rays of upper and lower limbs showed multiple well-defined osteolytic lesions in the small and long bones of upper and lower limbs. Along with that, multiple soft tissue densities were seen in hands, forearms, arms, and legs. Among them, some were calcific, causing pressure erosions of the adjacent bones. Here you can appreciate multiple punched out lytic lesions along with soft tissue swellings in both the forearms as well as in the legs. So what do you all think? What could be the cause of multiple lytic lesions in this patient? Multiple lytic lesions can arise in a number of disease processes like multiple myelomas, bony metastasis, histiocytosis, hyperparathyroidism, as well as secondary to infections. So to exclude these, we decided to go for further workup. Her X-ray skull was normal and it showed no bony pathology. Her skeletal scintigraphy revealed multifocal bone pathology involving bilateral radius, bilateral ulna, bilateral tibia, and small bones of hands, making the diagnosis of multiple myeloma and bony metastasis less likely, as in both of these, predominantly axial skeleton is involved. Also, the patient's age was not favorable of these conditions. Her serum parathyroid hormone levels also came to be in normal limits, ruling out hyperparathyroidism. On ultrasound of the swellings of hands, feet, arms, and legs, multiple well-defined hypoechoic cystic lesions were seen with internal echoes. No internal vascularity was appreciated on color Doppler study. Her ultrasound abdomen was normal with no visceromegaly, and her CT scan chest and abdomen with contrast showed innumerable soft tissue density lesions of varying sizes in the subcutaneous soft tissue of imaged body. These did not show any significant post-contrast enhancement.
So on the basis of normal chest X-ray, normal serum calcium levels, normal ACE levels, the differential of sarcoidosis is nearly ruled out, but the 3 other differentials are still cannot be ruled out without the biopsy. And the question is still in our mind that are we dealing with 2 different diseases or these are one disease? So let's see if the biopsy is able to solve this mystery or not.
So to rule out rest of the differentials, we decided to go for our deep skin biopsy, for which general surgery was taken on board. Our deep skin biopsy was taken from a nodule on her left forearm and it was sent for histopathology as well as for microbiology. While her cultures were still awaited, we received the report of histopathology which showed sheets of foamy histiocytes along with numerous multinucleated giant cells with engulfed pigmented fungal sclerotic bodies consistent with chromoblastomycosis. No evidence of tuberculosis or malignancy were seen. When the patient presented to us, she had already gotten a skin biopsy done from a pigmented plaque on her chin in Peshawar and its report was still awaited. Meanwhile, its report also came suggestive of chromoblastomycosis with large number of multinucleated giant cells engulfing pigment fungal cells. Periodic acid shift stain was highlighting fungal organisms within the giant cells. Her pyogenic cultures, fungal cultures, and AFB cultures showed no growth. So on the basis of characteristic histopathological findings of sclerotic bodies, the diagnosis of chromoblastomycosis was finalized. As our patient had extensive cutaneous lesions and bony involvement, we decided to start her on a combination therapy with capsule itraconazole 200 mg BD and tablet terbinafine 250 mg OD. Her lesions started improving by second month, and on follow-up visit at 6 months, there was marked improvement and visible clearance of the lesions on her face as well as on her body, as can be seen here. As our patient had markedly improved, in order to avoid excessive load on liver, her tablet terbinafine was discontinued at 6 months, while itraconazole was continued. Patient remained in Karachi for over a year for her treatment, and after that, she went back to her village. Due to COVID conditions, she could not come for follow-up physically, but she's still in contact with us via phone. Moving on to literature review, we came across some interesting articles regarding chromoblastomycosis, from which I would like to share a few of them. This case of chromoblastomycosis with skeletal involvement was reported in 2016 by Services Hospital, Lahore. 20 years old female presented with hyperpigmented verrucous plaques on both sides of face. Similar scattered lesions appeared on ears, arms, dorsum of the right hand, trunks and legs over a period of 5 years along with skeletal involvement. Radiological findings showed lytic lesions in terminal phalanx of the left index finger, loss of terminal phalanx of little finger, lytic lesions of second metatarsal and digits of left second toe. Skeletal scintigraphy showed multifocal bone pathology similar to our patient. Another case was reported by Khyber Teaching Hospital in 2019 of a 12-year-old boy with a history of pruritic, dark verrucous plaques extensively involving all parts of the body with secondary involvement of bones, cartilage, tongue, and palatine tonsils. X-ray of the hands and feet showed expansile multiloculated lytic lesions and periosteal reaction involving the terminal phalanx of the right little finger and the right fifth metatarsal. There was narrowing of the joint spaces of the digits involved. There was partial resolution of the phalanges. A case study was done in India in which 169 cases of chromoblastomycosis were studied, and it was concluded that more than one type of lesion can develop in advanced severe cases. The known sites of metastasis are the lymph nodes, brain, and lung. However, the disease seldom involves bone. Bone lesions were reported in 3 cases, among which in 2 cases lesions were not established to be directly due to fungi. An osteolytic lesion at the head of the metatarsal underlying the cutaneous lesion was considered to be due to contiguous spread in the 3rd case. A case report from Brazil was published in JAD 2010 of a patient who presented with verrucous plaques and multiple nodular lesions extending from the knee to the root of the left thigh. The patient was started on the combination treatment of itraconazole and terbinafine with excellent results and significant reduction of lesions with only 2 months of treatment. They commented that treatment with one oral antifungal in most cases does not produce good results. Up to date, there is no universally accepted oral antifungal combination scheme for the treatment of chromoblastomycosis, but the result of the combination of itraconazole with terbinafine has been quite promising.
So this case is unique because in the previous literature search, we have found that the lytic lesions are associated with only plaque type lesions, or the lytic lesions are associated with the nodular lesions. But in our case, all 3 types of lesions occur together. So this is a very unique presentation. And second thing is that the cases of deep mycosis or subcutaneous mycosis, like chromoblastomycosis, the patients which we come across, the lesions are usually pigmented verrucous type. But here in our case, the soft tissue nodules are skin colored and soft, enlarged nodules. Second, the cases which were presented in the previous literature and as well as our case, all patients are immunocompetent. The HIV status of our patient is also negative. Then comes the management issues. This mycosis is still of therapeutic challenge because of the recurrence of the lesions, and chromoblastomycosis has the characteristic of its treatment refractoriness. A study was published in Medscape in April 2021. It was an Indian study in which 25 cases of chromoblastomycosis with variable severity were picked,
and they were started on itraconazole. The author suggested that the quality of itraconazole is bad. There was dramatic improvement in the first few months, like that in our case as well, but the long-term cure was rarely achieved. This is because of the fungistatic nature of the drug. So they suggested that the combination therapies are superior and itraconazole should be given with vinafine as was suggested by the JAD article, or the combination of itraconazole and flucytosine can also be started. And the treatment should be continued for 5 years, because otherwise when the treatment stops, the lesions recur. Second thing is that the bone lesions are very rare presentation, and the previous studies show very few cases of bone lesions, and they suggested that the bone lesions are due to the metastatic nature of the disease, or they can be because of the direct invasion from the soft tissue lesions. Now, the take-home message is chromoblastomycosis lesions are polymorphous, verrucous, nodular, tumoral, plaque-like, and atrophic. Bone involvement is possible, as we have shown in our case, in the form of lytic lesions, which is very rare in the literature. And strong clinical suspicion and early diagnosis could be very beneficial in avoiding complications and disfigurement. So we concluded that whenever a case is present with multiple cutaneous findings, it's better to fit them in under the umbrella of a single disease rather than classifying them as two different diseases. So with this, I would like to hand over the session to Dr. Reema Mirza for the welcome, for the thank you.
Okay. In the end, I would like to thank the dermatology departments of Jinnah Sindh Medical University, PNS Shifa, Aga Khan University Hospital, Institute of Skin Diseases, and other respected audiences. Also, special thanks to Dr. Yasir Mubarak and the team of Brooks Pharmaceutical for all the arrangements. I hope that the efforts of our postgraduate students and seniors have helped to some extent in promoting clinical dermatology. Now, the next session would be conducted by Jinnah Sindh Medical University, inshallah. I now conclude this session from Civil Hospital, Karachi. Due to lack of time, question answer session will not be conducted. For any queries, you can contact on the email address coming on the screen. email addresses आने चाहिए. Okay, we have this email address on the screen. So for any queries, you can contact on this email address. Certificates from PAD would be given to all the attendees after 1 to 2 weeks. I now request Mr. Shahid Sheikh, who is the General Secretary of Pakistan Association of Dermatologists, for his valued comments. Thank you.
Assalamu alaikum. Assalamu alaikum. Are you listening me?
जी वालेकुम सलाम सर.
Madam, mashallah, well done your team, your seniors, colleagues, and your mashallah postgraduate students presenting a very wonderful presentations on two rare cases. I really appreciate your colleagues, your hardworking, and your postgraduate students presented both cases in a very nice way. Both cases having a skin manifestations with internal involvement. One case is having on the other side organ involvement like hepatosplenomegaly and lymphadenopathy. And the other case, mashallah, with bone involvement. So this is very important, two aspects. One aspect is organ involvement with skin manifestation, and the other is skin manifestation with bony involvement and lytic changes. Both are rare. The actually short of duration of disease in first case is very small. Remember, I think so. It's 21st September 21. 4 months history of presentation, and you done very good hard working on that case. You did not leave it as a usual case. You take it seriously, and ultimately you make a diagnosis. So this is a time to make a clinical dermatology to more important. So this is the presentation of your PGRs. This will develop a confidence. This will having a good guidelines from your seniors to have a such cases and having a rehearsal in futures. In in my tenure when I was PGR, I saw a case of chromoblastomycosis, and I have seen a first time copper penny bodies in histopathology scattered in the dermis. That was very, I am lucky to see that copper penny bodies, and I am very happy. At that time, I learned it was present on the pressure areas like the TVC, TVC tuberculosis verrucosa cutis. You have to differentiate the both because both have the cauliflower presentations on the skin. But I have seen no the bony involvement in chromoblastomycosis, which I haven't seen before. So I appreciate your all mashallah seniors because I have seen also it's a department of Dr. Zanaz Vahid and your team and your mashallah postgraduate residents. So this is our aim to make our services not only local level, but should be spread to the national level, not to the national level, but international level. I give you very good news in this presentation. We have got win a prize in Dubai Derma. In this presentation, I have seen a slide which I presented in Dubai Derma. Dr. Sania Javed from Services Hospital. You have seen the first author is Dr. Sania Javed, second is Saila Batul, and third is Professor Shabaz Aman Saab. I was just new at that time when I have seen this is a real case in my department, and we make history examination and all about this presentation. Actually, these are two children, two brothers presented in Dubai Derma, and we got a first position in Dubai Derma. So it's a very excellent exercise. I really appreciate your efforts, and I am really very happy. Can't express my feelings. What a presentation! Excellent presentation. I have more words. I have more words, but unexplainable, because they are more than that and unexplainable words. Really very happy to see all of you, to all of your postgraduate students, to see the cases with skin manifestations as well as internal organ involvement. Both. This is very important. Thank you very much. Inshallah, Dr. Yasser from Brooks Pharma, we will also thankful to Yasser Bhai. He facilitate us in a virtual meeting and share the excellent knowledge nationally as well as internationally. What a presentation, and we will show it in the PAD forum, and we will distribute. I have seen first it was 88 about participants, no, not 60. We will present to PAD certificates to all the share their address, their PAD numbers, their PMC numbers, and we will, inshallah, distribute the certificates to them. The certificate having the same format. Thank you very much.
Sir, thank you very much for your valuable comments, sir. We really need that, and we will be needing that in future as well. And sir, more than 90 attendees were there, according to my consultant. And sir, thank you very much for your valuable comments. With this, we want to end up. And the next session will be conducted by, as Dr. Rima has announced, by Jinnah Postgraduate Medical Center. So, inshallah ta'ala, we will continue this practice either in this way or in physical way, because of the in the beginning there was a dropout of the internet. That's why it was delayed. Hope you have enjoyed, and inshallah we will continue this practice, and we will gather on one forum in order to promote clinical dermatology. Thank you very much.